Good day everyone, I am Victor, the moderator for this webinar. I welcome everyone for today's webinar, which is Secrets to Correctly Billing Shared Care and Incident to Services in 2024. I would now like to introduce our presenter for today, Jan Rasmussen. Jan Rasmussen, PCS, ACS OB, ACSGI as a healthcare consultant. Jan has over 45 years of experience in physician billing, reimbursement and compliance. I would now like to hand over the floor to the speaker. Over to you, Jan.
Thank you, everyone. Thanks for joining us today. This has been a hot topic this year, the shared care. And part of the problem is we're dealing with compliance. Explore the differences pretty much between shared care and incident to services. Recognize the changes to shared care in 2024. Review some of the specific guidelines for each service. Understand the reimbursement issues. This is a huge issue for incident to and shared care. Define QHP providers. Also, we want to understand which services require orders. Last of all, we want to look at how other payers view these Medicare policies. Basically, all physician groups that employ QHPs, or the old word was NPPs, non-physician practitioners, can be faced with billing Medicare for their services. The key issue is the differences in how these services are reimbursed. Failure to comply with the shared care and incident to rules. What happens if you don't comply with them? What is a QHP NPP? QHP is Qualified Healthcare Practitioner. NPP is Non-Physician Practitioner. What are the supervision guidelines for NPPs, non-physician practitioners? They must always be supervised by a physician. Some states specifically limit the services that the nurse practitioner can provide. PAs, physician assistants, also have scope of practice, and the regulations may also, be by state. Scope of practice is determined by the supervising or collaborating physician at the practice site. Clinical staff. Now, clinical staff is totally different than QHP, NPPs, PAs. They work under the supervision of a physician or a QHP professional. What is included as a clinical staff? Medical assistants, licensed practical nurses. Now, clinical staff can do immunizations, supervision of tests. So let's get specifically into shared care now that we went over the basics here. Split or shared services are actually E&M services where they are performed jointly between a physician and a non-physician practitioner / QHP. The QHP or NPP must be employed in the same group practice by the physician. CMS requirements for split shared care. Now, unfortunately, there were significant changes, and under the 2024 final rule, medical decision-making actually has 3 individual components: the number and complexity of the problems addressed, the amount and complexity of data to be reviewed and analyzed, and risk of complications based on morbidity or mortality based on the patient management. CMS says medical decision-making is not easily attributed to a single physician or nurse practitioner PA when the work is shared. Now, here's another thing that changed. In 2024, CPT actually put a section in there in the E&M guidelines on split shared care. For the purposes of E&M service and team-based services, as I said earlier, may include both face-to-face and non-face-to-face activities. These can be used as substantive portion. What you can't use for time is the performance of other services that are reported separately. For all split or shared visits, one of the physicians or one of the practitioners, must have face-to-face in-person time. Well, I've got a couple of examples here we can work through and see what we think. Here's the next one. Here's another one. Critical care services are only ever reported based on time. Time is not a factor in the ER setting. Services may be reported only in the facility setting. Prolonged attendance, that's another issue here. Prolonged services can only be based where the service is based on time. They would add that time together. Okay, let's hit incident 2. Incident 2 really has not changed a whole lot this year. Incident 2 services can only be performed in the physician office. The physician has to provide direct supervision. If auxiliary personnel perform services outside the office setting, whether it be a QHP or a staff person, the physician technically has to be there at the same time. They have to be in the patient's home or the hospital or the skilled nursing facility to bill Incident 2. Now, behavioral health, 2023 Medicare Physician Fee Schedule final rules allowed general supervision when delivering certain behavioral health services. Public health emergency temporarily changed that direct supervision rule to allow the supervising physician to be remote and use real-time or interactive audio-video technology instead of requiring the physician's physical presence. And this flexibility is extended till December 31st, 2024. We're not sure what's going to happen January 1st, 2025. Now, here's another problem. Incident 2 rules do not apply to a new patient or when treating an existing patient for a new illness or injury. Incident 2 services do not apply if there's a change in the plan of care. Both the credentialed physician and the qualified QHP staff providing the Incident 2 must be employed by the same group entity. Documentation, they have to identify the performing provider. Commercial payers, some specifically exclude Incident 2. UHC allows Incident 2 and shared care billing, may require modifier SA for Incident 2 services. Well, thank you, everyone. This has been a confusing year this year with different issues going on, and hopefully we can train our providers, whether they be physicians, nurse practitioners, or PAs, to document so that we can get the best reimbursement we can.
So that does conclude the session for today. Thank you everyone for participating. You may all disconnect now. Have a great day ahead.